Okay, so let's keep moving on. We're going to switch over from congenital heart disease, and we're going to start talking about the important organ, and that is the aorta. And so we're going to hear from Dr. Goldstein, who's going to tell us about imaging techniques. Which one's the best, echo, CT, or dynamic MR?
And the answer to that is they're all excellent, and they all have specific places, et cetera, and we'll go over that. You've heard two really superb talks on some very challenging conditions, adult congenital, and this is now going to be the first of three discussions on aorta. I have no conflicts of interest. I want to congratulate you guys here in Houston for your victory last fall. So congratulations, but I caution you that next October, you all are going to be playing the Washington Nationals in the World Series, and just watch out. Now, yesterday there was a bit of conversation about obesity and BMI and et cetera, so I thought I would share this with you. Most of you know this is a very famous statue of David from Michelangelo that was loaned to the United States for a while, and when we returned it back to Italy, this is how we returned it. So, enough for obesity and our problem in the United States. A big challenge in this country now, where probably a third or more of our citizens are obese. So this is the source of some of the material that I'll be sharing with you. Something that I had the privilege of being involved with in about 2 years of my life. Measuring the aorta is one of the things that we certainly need to do, and we suggest that you measure the annulus, and that was gone over very carefully yesterday, both in the lectures here and in our special session on TTE. Mike Quinones went over how to do that. We typically want to measure the aorta at the sinuses of Valsalva, sinotubular junction, and as far up the ascending aorta as we can get. Now, echo, transthoracic echo, is great for the root. We do very well, just about as well as any imaging position, but above the sinotubular junction, we may or may not do a good job. CT scan and MR are superior. We may do a good job in some patients, but we fail in others for a variety of reasons. Also, we want to be perpendicular to the aorta no matter where we measure it, otherwise we'll get false diameters, and that's very important, and one of the reasons why we should be measuring patients in the same fashion, putting prior studies, serial studies, side by side. Now, we actually have a whole host of imaging modalities listed here. Time doesn't allow me to go into all of those, and I'll be focusing largely on echo, CT, and MRI a little bit, with a large focus on echo, because that's what I do in life. I have a little bias there. There are many diseases of the aorta. I'll list some of them for you. What some people have termed acute aortic syndrome, aneurysms, with or without association of genetic diseases, trauma, etc. You heard about coarctation already this morning, and time again doesn't allow me to go into all of those. A little bit of focus on acute aortic syndromes, which was the term was initially coined. It's sort of like ACS, acute coronary syndrome, was coined a few years ago, as you see here, about 15 years ago, from a Spanish group of physicians. Now, these are important because it's really key to make these diagnoses quickly and accurately and correctly, because they're among the most fatal diseases in the world. Myocardial infarction today, for example, the mortality is gone way down. These conditions are far more fatal, although fortunately far less common. All of these conditions involve some sort of disruption of the aortic wall. The clinical picture can overlap. Typical aortic pain is pain that begins suddenly, right away, maximal intensity right away, often hypertension. Up to 80%, 75-80% of patients with aortic dissection have a history of hypertension, but hypertension's not the cause of the problem, it's an association. And these patients need care very quickly, and that's where imaging comes into play. These are the conditions. I won't have time to discuss penetrating ulcer. I'm going to focus largely on the first two simply because of time limitation. Now, CT scan and echo, largely TEE, are usually among the first two the first two procedures that these patients get. And the majority of them nowadays, CT scan in about 70% of patients is the first procedure. This is a cartoon and then a real picture of what aortic dissection is. This is the lumen of the aorta. This is the intima, media in pink. And if there's a rent or tear in the intima, allowing access of blood to the media, to this pressure from the lumen under pressure, the media will disrupt and then will typically propagate longitudinally, and usually in a dissection, whether it starts in the ascending or descending, they usually propagate all the way down to the iliacs. That would be the typical situation. This is a beautiful one of our pathologic specimens showing the lumen over here. This faint pink is the intima, and this is media here on both sides, split by a column of blood. The term intimal flap is often used. It's actually an incorrect term. It's not the intima that's a flap, it's intima media. And that gets to be a little mouthy to say intimal medial flap, so it's easy just to say dissection flap, and we'll talk about that in just a moment. All of the imaging modalities, we want to identify where the site is. It's very critical to determine if we're dealing with ascending aorta, a type A, because those patients almost all immediately go to the operating room as quickly as possible. In type B, we tend to manage medically, although more and more now with TEVAR, with stent grafts and so forth. We want to know, are the coronary arteries involved, and then a series of other things that we look at. The aortic valve is involved in roughly half of patients with aortic dissection type A. We want to know why, how severe, does it need to be addressed or not, and how. Pericardial effusion occurs if there's rupture with a type A dissection and a type B dissection. If and when it ruptures, will go into the left pleural space, so they differ to where they go. Branch ischemia, we're concerned with also. Now this slide you can't read, it's too small, but it lists some of the procedures that I've mentioned, CT scan, TEE, MR, etc., and goes over the relative advantages and disadvantages. I'll summarize those just a little bit for time's sake. I've mentioned already that CT scan tends to be the initial diagnostic test in the majority of patients in this era. We fortunately or unfortunately, because we get called in the middle of the night a lot, but TEE is almost always done in our patients in addition, typically when they go to the operating room, but it's very common for us to do transesophageal echo in our hospital. Very widely available. Essentially every hospital has CT scan, very high diagnostic accuracy, doesn't require an operator dependency like TEE does, etc., and can see the entire aorta, arch vessels, the abdominal aorta, etc., etc. There are some downsides to CT scan listed here, and for time's sake, I won't go over them in detail. TEE is also very highly accurate, inexperienced hands, very widely available in this era, terrific for pericardial effusions, LV function, presence and mechanism of aortic regurgitation. We always look at the coronary arteries, or at least attempt to. We can do it on very ill patients, which can be a limitation with the other modalities. In some patients, we can do this in the hallway, emergency room, cath lab, operating room, etc. And it is the procedure of choice for guiding procedures in the operating room. This is an older series of patients over roughly a decade, but approaching 700 patients, and you can see the sensitivity of transesophageal echo accuracy is very, very high. Some downsides, It does require experience, and some smaller hospitals, you may not see dissections often, you may not have opportunity to gain experience. We're not so hot on the head vessels, all of them, the vessels below the abdomen. It is a little bit sort of semi-invasive, so-called. I think we've sort of a little bit grown past that in this era. MRI, also very accurate, has a beautiful resolution. The pictures are gorgeous, but not so easy in patients who are critically ill on ventilators and other situations. CT and MR are the preferred choices for serial imaging. We don't do TEE on an annual basis after repair of aortic diseases, et cetera, et cetera. Not as widely available. I've mentioned already, not so easy in very ill patients. Takes a little more time, although that's getting better, and there is an issue with gadolinium in some patients. This is a very small study, only 50 patients, but it's the only study that I know of that compared all three of the modalities that I've just mentioned in the same group of patients. So all patients had all three. And this is older. This is not multi-detector CT scan. It's old-fashioned helical or spiral CT scan, but all of them were highly accurate in these 50 patients, nearly 50 patients. About half did have, half did not have dissection. So all of them very good. Now, why is TEE such an excellent procedure? This is an interesting transthoracic echo, peristernal long axis view, and you see the ascending aorta here, the descending aorta here with color showing it, and this little creature right here is the esophagus. This patient had cancer of the esophagus, and this is a plastic stent to keep it open, and it shows you how proximate we are to the descending and ascending aorta and illustrates why TEE can be so good. Echo findings, the dissection flap is really the hallmark of this diagnosis. And with transesophageal echo, these are normally a slam dunk, a piece of cake. I say normally. There are some instances where we sweat a little bit, but usually that dissection flap is very distinct, and you'll see a few. And that divides the aorta into two lumen, true lumen and so-called false lumen. Most of the time, but not always, the aorta is dilated. Unfortunately, dissections occur in people with initially normal size aortas in some patients. We look for reentry sites, and they're very common. The harder you look, the more you'll find with transesophageal echo. We're the only technique that really identifies these little reentry sites, and they're the reason why the false lumen stays patent in roughly 80% of patients even after repair. Aortic regurgitation I've alluded to, and ruptures into pericardial or pleural space. Dissection flaps are mobile. Unless they're chronic, then they may be less mobile, but acute aortic dissection, they tend to be mobile, such as seen here. The motion is independent of that of the aorta. We like to see them in multiple views to help distinguish them from a variety of artifacts that may shadow outside the confines of the aorta, et cetera, and sometimes seen only in a single view. This one is a still, but shows you this folded, convoluted flap in the ascending aorta. This is the LV outflow tract, so blood is going in this direction in both of these cases by transesophageal echo. This one I've just shown you in a smaller format, and this is a typical, very prominent, easy to see folded flap. Here's one where the dissection flap comes all the way down to the annulus, disrupts the aortic valve, causing prolapse and aortic regurgitation. This is a descending thoracic aorta in cross-section, showing a true double barrel or nearly double barrel aorta with the true lumen in the center and the larger false lumen surrounding it, with more rapid flow in the true lumen. In this lighted room, you can't see, but there is a dull red here. There is flow in the false lumen, but not easily seen because it's so low velocity in this picture. And the false lumen is nearly always larger than the true lumen in the descending thoracic aorta. A couple of patients that had both TEE and CT scan to show you how similar things look. This is the true lumen here by TEE, and you see the shape is very much the same. false lumen over here, and this is a little accessory flap that wiggled and wasn't picked up by CT scan because of its motion. This is another patient. This is CT scan of the arch showing true lumen with more contrast in the center, outlined by the dissection flap, and you can see how very identical that looks on TEE. Look at the flap here. This is the true lumen, false lumen, how similar they look when lined up side by side. This is one of our cases, a couple of different views to illustrate how these flaps can look. They dance, they oscillate, etc. This dissection comes down nearly to the aortic valve. This one is not playing for some reason. I apologize. Aortic regurgitation, I don't have time to go over this list. These are all in your handout with the flash drive that I gave this morning. All of these slides are available to you. But dilatation of the aortic root, separating the leaflets is a very common cause. Some patients get like an intussusception. The dissection flap will actually prolapse into the LV outflow tract and cause aortic regurgitation. This slide you've already seen, a different mechanism of aortic regurgitation. Pulse loss, two mechanisms. The false lumen, as illustrated here, if and when it expands, can actually compress the true lumen here, and in this case, innominate artery, or the dissection flap can actually enter and involve and obstruct an orifice of any of the aortic vessels. Let me just share a few cases with you. This is a middle-aged man who had a dilated aorta detected. He actually had hypertension, and a routine chest x-ray showed an abnormal aorta, CT scan, and he was actually due to see physicians, but about a week before, right around New Year's, on his way to work, he collapsed with syncope. 20% of patients with acute type A may have syncope, and this is a transesophageal echo, deep gastric view. The LV is here, and this is clot and fluid in the pericardial space. So he ruptured, and we always look for that. This is LVH, small cavity, very thick walls, decent contractility, and you can see pericardial effusion that looks a little smudgy, probably bloody in the pericardial space. Here's his dissection flap, shown here in a 0-degree view, and we see it here in a longitudinal view. The aortic valve is here. The dissection flap is beginning at the sinotubular junction. Here we're focusing on and illustrating the right coronary artery, and we always try to identify these and illustrate flow into them to make sure the dissection doesn't involve. He had only mild aortic regurgitation. I'm not sure why this is not playing, but there was only mild aortic regurgitation. The left coronary artery is illustrated here. Another case that's not showing. They did last night around 11 p.m. I don't know why here, but at any rate, you've seen already enough good examples of aortic dissection, and you can see why they're fairly easy. Now, a variant or an atypical aortic dissection that is often termed intramural hematoma differs from classic dissection, pardon me, in which a dissection flap separates true and false lumen. There is no true and false lumen in this instance. The media contains hemorrhage from one of two mechanisms. Notice that the lumen is normal. Aortography, which used to be many years ago gold standard, now is off the map. It's a tarnished, not even a bronze standard anymore. CT-MR and TEE are the methods of choice, but the lumen is normal, and aortogram, which is a luminogram, misses many of these. So they're missed by aortography. False negative aortograms is shown here. These account for in the range of 10 to 20% of all aortic dissections, as opposed to spontaneous dissection, typical type, where type A is more common than B, that is ascending more than descending. These are more common in the descending thoracic aorta and I emphasize the normal lumen. This is a compilation of more than 1,500 patients collected over a 15-year period, and you see the percentage of intramural hematomas in these various studies averaging about a little over 15%. Focal thickening of the aortic wall, preserved lumen with smooth border, not lumpy bumpy, typically absence of a dissection flap, and sometimes we see lucencies within the hematoma in the media also. A couple of examples by transesophageal echo, normal lumen, very thick wall, often crescent shape as illustrated here. This one is nearly concentric, but notice the normal lumen, smooth wall, another one, crescent shaped. CT scan, same finding. The lumen here, normal, and this is the blood in the wall of the aorta. MR, similar findings. These can rupture, so in the United States at least, we treat them like we treat a standard dissection. If they're type A, they typically go to the operating room. At type B, we tend to manage them medically, etc. So they can rupture, they can progress to a classic dissection, they can regress and actually disappear altogether. So that's the natural history of those, illustrated nicely by Arturo Evangelista in some longitudinal studies. Another middle-aged patient, this one a lady who presented to us with what was felt to be on the outside coronary disease. She did have some lesions, was sent to us, and a 2D echo showed a lot of aortic regurgitation, a pericardial effusion. We did a CT scan and changed the diagnosis. Oh, sorry, this was done at the outside hospital and then sent to us for surgery. And this is the patient's ascending aorta. The aortic valve looks normal. The shape of the sinuses are perhaps a little bit prominent dilated, but this is an intramural hematoma. This wall is very thick. And you can see here, surrounding in the entire aortic root, surrounding the left coronary artery. Flow into the left coronary artery was normal. And in the descending thoracic aorta, the patient actually had a more classic or standard dissection with true lumen, false lumen. There's a little left pleural effusion here as well. And you can see there's some accessory things in the false lumen in that patient. So to summarize, our imaging techniques with CT scan, MRI, and echo have really helped us tremendously in these diseases. They're all very accurate. Your choice should depend on how available they are and the expertise at your own center, and look at some of the other features of them. TEE is good for the root, but is limited for the ascending aorta. I'll let you read these, but I'm just going to outline for you in the last two slides. In the paper that I've mentioned to you before, there's a list of some of the relative advantages and disadvantages of each of these procedures for a variety of aspects of aortic dissection, etc. I'm going to stop there, but I would like to thank, in closing, this is my last presentation with you all. I want to thank Dr. Zogby and the others here. Pardon? This is your Dr. Zogby, by the way. Looks a little bit different now, but I think he looks terrific now, to be honest. He deserves a hand, but this is his beautiful wife and Bill at a very young age. Thank you very much.